We're now moving into our research presentations, and over the next 45 minutes, we'll hear from three presenters, academic family physicians that represent various sites from across the DFCM and whose work spans community participatory action research, education scholarship, and digital innovation. So first off, we have Matt Orava. Matt is a comprehensive family physician practicing and teaching at the Barrie FMTU as part of the Royal Victoria Hospital academic site. He's the associate lead physician of the Barrie Family Health Organization, chair of the board of directors of the Barrie and Community Family Health Team. He's currently the Tristan Lawson Distinguished Fellow in Child Nutrition and Community Engagement, supported by the Joanna and Brian Lawson Center for Child Nutrition at the University of Toronto. When not in clinic, you can find him spending time with his wife and 4 children, and he will be presenting on his work entitled Healthy Barrie, a community-based partnership to improve health and wellness in the city of Barrie.
Well, thanks for having me. It's a bit intimidating to have a lot of mentors in the room, so thanks. Over the next 10 minutes, I will be talking about the Healthy Barrie Initiative, a community-based partnership to improve health and wellness in the city of Barrie. For conflicts of interest, I have fellowship funding from the Lawson Center for Child Nutrition. I receive honorarium for my board of directors work. I am a sub-grant recipient for the Better Woman project, and I have research travel awards from RVH Research Institute. So what is Healthy Barrie? Healthy Barrie is a collaborative between government, primary care, research, and public health for our city of Barrie. So from the government perspective, we have municipal participation with the mayor's office at the city of Barrie. We've gone through 2 mayors and have sustained it, so we're pretty proud about that. From primary care lens, it's the Barrie and Community Family Health Team. What's unique about the city of Barrie is we have 104 family physicians, and we're all under the same family health team. And within that, we have a shared EMR record of both allied health as well as physician health, and so we can capture about 70% of the population in one EMR. From the research lens, we have participants from the University of Toronto Dalla Lana School of Public Health, the DFCM, and now the Lawson Center. And finally, we have a strong presence of public health. The Simcoe-Muskoka District Health Unit is at the table and partners with us. So what do we do? Some of the early projects were the low-hanging fruit, easy wins. We did a Parks RX project where we basically gave prescriptions to spend time out in the park for people who were struggling with mental health and anxiety. The health unit liked it because they wanted to see how people got to the park and what they did there. The city liked it because they're using the parks and what we invest for park infrastructure. And the family physicians participated by looking at a different way other than SSRI to help treat anxiety and depression. Where we struggled is winter in Barrie and not a lot to do in the parks. Active people, we did a project to get people increased physical activity, specifically in the geriatric population, and an active school travel project to get kids to walk to school instead of get a ride. In 2019, prior to the pandemic, we sat down and said, what could we do at a bigger level? And one thing came to big data. We wanted to see if we could bring stuff together and really look at what was happening within our city. So this is a excerpt from the Chief Medical Officer of Health 2019 reported communities. But basically, we wanted to bring all of our partners together and share data to see if we could inform the city plan and inform changes in our city. So how did we do this? Basically, everyone came together with sticky tags, and we picked what indicators we had, what was available, and we kind of ranked them based on relevancy, validity, reliability, compelling. We really wanted something compelling so you could talk to the funders about doing things. Easily understood. Available was also obviously something that was important to us, and collaborative, something that we could use across sectors. After using that indicator tool, we came up with these indicators, broken down into health behaviors, including alcohol use, fruit and veggie consumption, neighborhood characteristics such as walkability of our neighborhoods, healthy food options, green space, and we had different markers of that, but we picked parks, TRAP, which is traffic-related air pollution. We looked at service utilization from a primary care lens. The demographics of our population was provided mostly from census data, which was a bit limiting, and then health outcomes came from our EMR using SIPs and algorithms. Each group contributed different things. So the city of Barrie, we're pretty lucky. We had a city planner come to these meetings, as well as input from councillors, the mayor's office, as well as epidemiologists. Barrie also has a portal called Open Barrie, which they are pretty open to sharing all of their data, which was quite helpful. And then we had Barrie Community Family Health Team data and the Simcoe Muskoka District Health Unit. We broke the city down into what the health unit calls planning areas. So publicly, you can see our city data in 6 different neighborhoods, but in the back end, we can go all the way down to small postal code areas. Basically, the epidemiological tap dancing is something called principal component analysis, but basically we try to break down neighborhoods so they have similar characteristics related to socioeconomics. And in the end, we had 6 neighborhoods, and they do align with our wards, which helps us advocate both at the municipal office level as well as when we communicate to the general population. I have maps, just like this morning we talked about. We won't have time to look at those. If anyone's interested, I can show you the iterative piece, but this one might be a bit challenging to see from the back, but this is an example of what the platform looks like. On the left, we have BMI. Now, I recognize BMI is a measurement of size and not health, but BMI is greater than 30 in the quote-unquote obese category, and on the right, you'll have markers of food deserts. And there is a visual correlation here between areas that have poor food availability within our city and high obesity rates. When we showed this to the mayor's office, our mayor's first response was, I always knew and thought there was a food desert there. Now we know that, and maybe we can do something about it. So what can we do about it? Well, we start looking at some correlations. Again, the lay audience, we have to teach them the difference between correlation and causation, but we started running some algorithms. And with this big platform, we've done a couple, but this is just one example of one. So what neighborhood characteristics contribute to diabetes in the city of Barrie? We threw this in with all those indicators. We did a hierarchical model, basically put social determinants of health, really income level as the biggest predictor of diabetes, and then we layered in the regression analysis. If you have questions on that, I don't have my statistician here, but I can look you up with them. And so what do we have? So the data that we pulled for diabetes, we captured 84,000, almost 85,000 adults, which is about 70% of the census population in the city. Of those, we had 9.75% having a diabetes diagnosis when we use the Simpson algorithm, which matches the prevalence rate reported by Canadian Diabetes Association. For interest, 50% had a BMI greater than 30, and 25% had diagnosis of hypertension. When we throw them into the algorithm, we see positive correlations. As predicted, age correlated with diabetes. The older you get, the more likely you are to have diabetes. Low income level was associated with diabetes, but not as big of an effect size as we had predicted. And when we look back, the heterogeneity of Barrie is not very great. We do have really wealthy neighborhoods and only subsections. And there's the sampling bias. I would appreciate that those that are most vulnerable are probably not captured in the data that I'm showing you. And then interesting, the percentage of kids in the neighborhood was correlated with a higher risk of diabetes. And there are some studies that show that when you're looking after the little ones, you're not looking after yourself, and there's some evidence in the diabetes literature around that. The negative correlations, having a female sex identified on the medical chart was protective, and something that our city planner liked was the proximity to parks. And so the kids, in this study, the people who are living closer to parks were less likely to have diabetes, which may relate to physical activity. So next steps, there's opportunity to run further regression analyses. We've done the same work and seen similar patterns with childhood obesity markers as well as adult obesity. The nice part of this is we call it a snapshot, but we want to try to make it into a movie. And so the idea is it's iterative. We can repeat this, and with the algorithms, we can do it relatively quickly now. And then we're working on a health promotion plan, and the idea is bringing in our community organizations to tackle some of these. So it was really easy to have the partners come in, look at this data, and now pick something to act on. And what we don't want to fall in is the data trap of just looking at our data over and over again, and now we're trying to initiate things. So hopefully in the future we can come back and teach you about what we've had success on initiation. This is not done in a vacuum. Lots of supports across multiple departments, so I'd like to thank the people up on the slide. And thanks.
Thanks, everyone. Thanks for having me. This is going to be a bit of a change of direction from some of the amazing talks that we've had so far. So this is an education scholarship project that I'll be talking to you about. The talk's on professional identity and reconfigurations of care that occurred during the COVID-19 pandemic. So as you see up on the slides here, this is by now probably a bit of what I call a Captain Obvious statement. Much attention has been focused on the impact of pandemic disruptions on residency training. Most of these have focused on impacts on specifically on formal learning opportunities and training. Some of the prior work that our group did looked at the impact on clinical skill acquisition and on learner wellness, but there's actually been a lot less attention paid to the impact that these reconfigurations of training programs, of training opportunities, and of care had on professional identity of our learners. So that's what we're going to talk about. We had a paper come out in academic medicine last year entitled Detour or New Direction, the impact of the COVID-19 pandemic on the professional identity formation of postgraduate residents. And today I'm just going to highlight some key elements of that paper for you. So I'm going to just start by reminding us of the working definition of professional identity formation, and this has been in the medical education literature for probably the last decade, published by Cruz et al., which identifies professional identity as the process by which you come to think, act, and feel like a physician. So the whole notion of professional identity formation has really been challenged in medical education in the last little while, the last year or two, because of the recognition that this really probably reinforces status quo in terms of power dynamics and in terms of what groups are left out of what have sort of been referred to or deemed as what is professional. So what is not being challenged, however, is that professional identity is developed through a socialization process. So this occurs with other members of the profession or what we call your community of practice. So for family residents, this would be primarily the doctors that they work with and that teach them, so many of us in the room, but it's also a process that is developed through experiences with patients, with interprofessional colleagues, and with the public as well. So it's a really complex, dynamic process of developing one's professional identity. It exists both within the influence of the formal curriculum, so a lot of what we think we have control over, but it also exists outside of it. So it's influenced very much by informal interactions and hidden structural, cultural, and organizational factors in training. So the goal of our study was to look at the disruptions to training that resulted from the COVID-19 pandemic and the impact these had on professional socialization and therefore professional identity formation of family medicine residents. So what do we mean by disruption? So everything from redeployment, cancellation of formal learning opportunities, electives, and of course the transition to virtual care. So there were many losses that occurred during this time, but importantly, there were also many new experiences that resulted from these disruptions. So all of these offer a really unique opportunity to explore professional socialization by investigating the meanings that residents attributed to these massive curricular changes that were occurring in real time. So to explore this, we conducted interviews. We had 23 interviews over about a 2.5-year period with DFCM residents, so between 2020 and early 2023. And these 23 participants were representative both of geography downtown sites. We had about half the sites were from community or rural sites, You can see the gender breakdown there, and that we interviewed residents from a variety of graduation years, starting we captured some of them right at the height of the pandemic in 2020, all the way to graduation year of 2023. So I'm just going to talk for a second about how we conducted our analysis. So we conducted what's called a theory-informed inductive thematic analysis. So this is a bit different than a deductive approach where you start with a hypothesis and then you kind of see how your data fits into that. So inductive thematic analysis, really you read through the quotes which represent your data in qualitative research, and then you build from there. So we use a couple of theory-informed lenses to guide us. So we're interested in professional identity, so we really wanted to apply, first of all, lenses of formal, informal, and hidden curriculum to our data, for the reason I mentioned. And then once we generated our initial codes, we used a theory called symbolic interactionism as a framework to further inform our data interpretation. So I'm going to talk for a little second about symbolic interactionism. I don't know if there's experts in that here. I had never heard of this prior to 3 years ago, but it's a really interesting social theory that refers to how the shared meaning that we attribute to events, objects, and experiences can translate into the values that we ascribe to those experiences. So, for instance, how the residents attributed meaning to what they were experiencing during COVID-19, the reconfigurations of care and redeployment, and how this meaning resulted in the valuing of those experiences. So this allowed us in our data to go beyond descriptions of the changes that occurred in training due to the pandemic. And this theory allowed us to use symbolic interactionism as a theoretical framework that allowed us to explore meanings attributed and the values attributed, both from new and from disrupted and lost experiences. So this slide is just to sort of represent, it's this multi-layered lens that allowed us to conduct a multi-layered analysis where we could identify how the pandemic induced reconfigurations influence professional identity formation. So we categorized a lot of the really rich data we got from 23 interviews over 2.5 years into 3 themes. So I'm gonna speak briefly to the first 2, and then I'll present most of the data on the third, just so we can kind of focus down on it. So the first theme that we identified in our data was the impact of the disruptions to postgraduate training on resident learning and provision of care as family physicians. So the disruptions didn't always align with residents' expectations for the work of family medicine or how they would be trained in their training programs, as well as how they would provide that care later. So for instance, when we talked to residents who were redeployed to COVID assessment centers or to the ICU or wards, they didn't see that as aligning with what they thought they would be doing. But what we also found was that a lot of these new experiences also did reinforce their understanding of what it meant to be a family physician. So being a resource to the public in a time of crisis, they did identify with, as well as being an advocate for their patients. So in the second theme that we identified, residents told us pretty loud and clear how their experiences during the pandemic constantly blurred the boundaries between their personal and professional identities, much more than they had expected this pre-pandemic. And particularly, they describe how this impacted their sense of safety and well-being throughout caring for patients in the pandemic. So if you want to hear more about themes 1 and 2, come and grab me outside, or I'll encourage you to read the paper. But the next sort of bit will be, the bulk of data that I'll present will be centered around theme 3, which is the impact of curricular disruptions on residents' sense of membership in the profession and their relationships within it. So most residents felt, as many of us did, that the experiences of healthcare workers were very different than that of the general population, and that this shared experience throughout the pandemic provided them with a heightened sense of belonging within the profession. So you see a quote here, and as well, residents talk about the opportunity to contribute to the pandemic response by really leaning into their identity as service providers as opposed to learners. We know that tension exists in training programs, but the idea of actually being needed provided a greater sense, or an accelerated sense, of membership in their profession. So I'll actually read this quote. The sense of community and sense of camaraderie in terms of being healthcare workers and being told you're on the front lines and you're being told we're working together to help the rest of the population get through this pandemic. So that was really seen to accelerate their sense of membership and identity with their community of practice as family physicians. But of course, participants also really described the loss of social aspects of training as one of the biggest impacts of the pandemic. So beyond formal losses and mentorship opportunities in areas of clinical or research interests, they felt there were very few informal interactions that occurred with supervisors due to in-person restrictions and virtual care. So this resident says, we still have a lot of formal relationships, but probably less of the more informal. A person who you just talk to about what's going on in general, harder to have those conversations with lack of in-person accessibility to each other. And remember that these interviews carried on to really early 2023. So we know that these informal relationships provide important role modeling for trainees as they form their identity as physicians and move towards full participation within the community of practice. So this person says, I think in a sense, those kind of more informal conversations that often include discussions about life and things that aren't directly related to medicine, you know, how do you structure your life around a medical career? We think we missed out on some of that. So in addition, participants identified lost social relationships with their peers, and these were people that eventually will become part of their own community of practice. So this resident said, we haven't really had a chance to kind of build relationships and become colleagues in the sense where you can depend on people and not be afraid to ask questions or ask for help. So overall, our findings for this third theme around membership and relationship were that while participants felt the pandemic really, the restrictions negatively impacted relationships with peers and colleagues and teachers within the training program, the sense of working together towards a common goal in a crisis provided a heightened sense of belonging and membership in the profession. So to wrap up, disruptions in training due to the pandemic provided a unique window to explore professional socialization and professional identity formation in action. And we observed how changes to the formal, the informal, and the hidden curriculum all contributed to residents' understanding of what it meant to be a member of the profession. These questions aren't novel to the pandemic, but the pandemic allowed us this unique opportunity to think about professional identity formation in response to evolving societal needs. So the question is, how will training experiences and socialization during the pandemic continue to inform our understanding of what it means to develop a professional identity in family medicine? So not only do the experience of these residents have important implications for their professional identity formation, and there were hundreds of family medicine residents trained during this time that are now in practice. I know some of them are here today, but their experiences also highlight the role of training programs in supporting professional identity formation for all residents going forward. This is part of the work we do as educators in our department. So at this time, I would open it up for a discussion and questions, and we can talk about limitations and stuff like that. I have no statistical analysis, but if people have questions around our theory and analysis, I'm happy to take those too.
So I'm Tania Tajirian, and the title of my topic today is Advancing Through Digital Innovation and AI. And just heads up, of course, anyone in the tech world right now, if you don't use the word AI within the first 10 minutes of your presentation, you're in trouble. So we can move ahead. It's done. We talked about it, and we can start. So I have no disclosures except I'm coming here representing my fabulous teams at CAMH. The one below is the Division of Hospital Medicine. We are a small but mighty primary care physicians taking care of a lot of the physical health needs at CAMH. And the top one is the tech arm that's helping us with all of our digital quality initiatives. So the bad and ugly and the future of EHR. So again, I'm going to give you a bit of a background. Does everyone remember that pivotal, thought-provoking article by Dr. Atul Gawande in 2018 where he spoke about why do doctors hate their computers? That was really influential on the work that I started because of that article. And in it, I think it's very important to kind of understand that he was talking about, we're having increasing amount of technology being part of our daily practices. And EHRs, they were meant to improve the quality and the safety of our practices, but unfortunately, because they're clunky products, they ended up with increasing our cognitive load. There's a lot of information about what is documentation burden. So I always kind of say, I love this definition because it kind of explains it. It's that imbalance between the usability of a tool and the regulations and what is required for us to document. And it's not just the act of documenting that is giving us that admin burden, but it's that retrieval part. I always kind of say there's another layer of information retrieval. It's like I always say surfing the EHR. The big part of it is the information processing. There is tremendous amount of information thrown at doctors on daily basis. So how much time are you trying to find the information, and processing it is also increasing our cognitive load. So this is CAMH, the organization, and this is our very successful digital health journey. So 10 years ago, CAMH was the first organization. We went with the big bang implementation of the EHR, which is Cerner Millennium. We're coming up for the anniversary in a couple of weeks. We ended up attaining one of the highest levels of adoption of the EHRs in an organization, which is the HIMSS stage 7. Like you can see, like lots of successes. But if you look at the December of 2018, we received HIMSS Davies Award, which is really great. But that's when I became the inaugural CMIO. So it was interesting. CAMH was celebrating a lot of its successes in digital health, but our physicians at CAMH, 4 years after implementing the EHR, simply hated it. So there was a disconnect, exactly what we saw, which Dr. Atul Gawande was talking about. So what did we do? So the first thing that I did as a CMIO was I did an environmental scan. Where are we at CAMH in 2019? We used the Mini-Z burnout tool. At that point, 26% of our physicians and learners were burnt out. But guess what? 70% of our physicians blamed the EHR as #1 reason of their burnout. Spoiler alert, we repeated this survey just last year. I wanted to see how we're doing after 5 years of work. The burnout post-COVID, stable, which is thankful at 28%, but how much of it was related to the EHR went from 70% to just 50%. so it just kind of shows, but again, it's a disclaimer, I'm gonna explain how I think about that. So we had the environmental scan, we realized we had to do a lot of work. I took the approach of an evidence-based for physician engagement strategy. And I kind of felt very strongly about the 3 pillars. How do you engage your stakeholders to work together and inspire them to be part of the change? We worked on 4 different initiatives. The first one, how do you improve the fast handling of the EHR problems that we have? We developed EHR SWAT teams. The second part, which I feel very passionate about, development of engagement and leadership in informatics. We developed think tanks. The third part is data and analytics. We developed physician dashboards. I can compare my results compared to other hospitalists in my division if I'm spending too much time after hours on all of that. And finally, a lot of emphasis on education and investing in informatics tools like speech recognition. Communication was very critical, and we have monthly newsletters. But again, as you can see, it's not one thing that's going to fix the burden, but a lot of it is the engagement. While we were working on our engagement strategy, you have no idea how delighted I was when OMA, their burnout task force in 2021, came out and said 2 out of the 5 system-level changes for physician burnout. Guess what? It's the tech integration, again, in our daily practices. OCFP's survey in 2022, we're spending as primary care physicians 19 hours per week on admin tasks, and that's ridiculous, I would think. And 94% of primary care physicians in Ontario said that this burden is overwhelming. So I'm gonna give you the next couple of slides, couple of the things that we've been doing at CAMH, and a lot of these projects, initiatives has been utilized by other organizations. So the SWAT initiative, what is so unique about it? It's a multidisciplinary team. It's a group of physicians, pharmacists, nurses, clinical informatics. It's a team that we descend at a low barrier meetings for physicians and ask them, give us all your pain points. And every SWAT cycle has 3 rounds. The first one, we categorize the issues. Second part is, hey, Not everyone knows how to use the EHR very well, the education perspective. And the third one, I highly emphasize, is the accountability framework. Physicians and all clinicians are tired from putting tasks off, fixing things and not getting done. So we have a very clear framework for accountability. We started with physicians, but we moved now into a clinic mode where we're not just fixing the physician issues, but we're thinking from a patient care journey. Where are the parts of EHR that we can fix? This is my favorite, the physician think tanks. We've been meeting for the past 5.5 years on a monthly basis, and I kind of said I chair it. We have divisional physician leaders and liaisons across all the departments. We meet with the tech people, IT, on a monthly basis, and we are leading all of the changes of the EHR. What's the success of this, what's the reason? The leadership buy-in was critical from top down, but also physicians really started enjoying the work and understanding that they do have impact on all of the changes that's happening. And we made another thing. I felt very strongly we need to be part of the governance structure. So nothing touches physicians' workflows at CAMH without first coming to the think tank with a fulsome discussion. And I think that enabled our physicians feel that they are part of the process. We have shared accountability, and I want to just show, that is the dashboard. That's my report card at the top. And it kind of explains my data compared to the others, my pajama time, my documentation time. I'm considered to be a super user, so I'm able to help others. These are tailored little videos, and I kind of say it's made by physicians for physicians. And again, education in this tech part is very difficult to understand what is really feasible and it works. But again, I'm going to go back. So we repeated the survey, 5.5 years of hard work, and 50% of our physicians still blame the EHR as one of the main reasons of the burnout. So what do I personally think? This is going to be the game changer. It's the hottest topic. It's the AI scribes. I think Ontario MD, Ontario Health, I think all of the announcements everyone's seeing, there's a lot of excitement about AI scribes, and the preliminary results so far in primary care that's showing that it's going to reduce our inefficiencies of practice. What do I think about AI? I think it's going to be transformational in 5 years. We are going to be liberated from keyboards. I think it's going to help us to have co-pilots. I would love the co-pilot now to help us to do better with diagnosis and treatments and provide precision medicine. What are we doing with our EHR? So we are working as a co-design right now, developing our digital assist AI tool with Cerner. And I love that because finally we're developing tools from the beginning, co-designed by the clinicians. So a lot of people ask me, I'm CHIO now. What's the CHIO versus CMIO? CHIO is the health versus medical. It's thinking about the system level and not just thinking of implementations of EHRs. So what did we do? We had a little project. This is what we're doing at CAMH. I wanted to understand what's being done for digital wellness across TASN hospitals. Through TASN M table, we were able to do an environmental scan, 12 CMIOs last summer, and I wanted to know what are the things that we need to focus on. Surprise, 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 what the CMIOs said. Again, the importance of, in order to provide digital wellness, we need to standardize documentation. We have to automate, get rid of all of the stupid stuff that we're doing. Interoperability, like who can't pull their hair from all of these different HIEs. Feedback mechanisms for physicians. You really need to create that ability to have those conversations. Ongoing need for all of these digital tools for training and support. And finally, nothing is going to change without really doing reforms and policy changes. And finally, last two slides I'm going to say. So 5 years, we got a lot of interest in informatics at CAMH, and now this is the fun stuff. Making physicians engage in change enables you to tap them for other work. So what are we doing in hospital medicine division? There's a few of them here, lots of great initiatives. And what we're hoping is the hospital medicine, we have an innovation hub, and we want to be the leaders of integration of physical with mental health. We just published last year our recommendations for organizations. And the first work that we did, we got a small CHR grant. We worked with UHN and with Cancer Care Ontario, and we developed for the first time through the EMR our ability to provide colorectal cancer screening for patients with severe mental illness, long-stay patients at CAMH. We were able to increase our screening rates from 13% to 36%, And it was it's work of love. Like a lot of people at CAMH enabled this work to happen. We took this template and now we moved it to women's health, the bigger issue. So this is like fresh off the hot press. We worked now with Women's College Hospital. Dr. Lofters is here. Here she goes. And with the radiology department, where we kind of developed a desensitization video. Our patients with severe mental illness can see the video, what it looks like to have a mammogram in order to encourage the compliance. And we developed bridges with Women's College, where we've done mammogram blitzes. And just a couple of weeks ago at CAMH, we did our first PAP blitz for patients with severe mental illness. So finally, I just want to close it. I hope my story showed how a learning health system enabled by digital innovation can improve the quintuple aim of health. I look at this and I see there is so many digital tools that are going to improve the quality of care we're providing. Think of personalized medicine, precision medicine, the health equity data that's going to drive a lot of the work, and it's looking forward to the future. That's it. Thank you, everyone.